Being here at Creighton is the opportunity to work with my colleagues in all the health sciences. And I'm delighted that Dr. Rowen Zetterman, the Dean of the School of Medicine, is going to be with us today to share his perspectives on how care is integrating and how we can collaborate, both as educators and as clinicians. Dr. Zetterman has been Dean of the School of Medicine here since 2009, but on faculty since 1977. He has served most recently as the Chief of Staff for the Veterans Affairs Nebraska Western Iowa Healthcare System and has also served as Chief of Staff for the Nebraska Health System. He is an internationally known researcher, particularly in the area of liver disease, liver transplantation, and has studied extensively the evaluation and care of patients with primary biliary cirrhosis, alcoholic hepatitis, autoimmune hepatitis, and chronic liver disease. Currently, he's serving as on the Accreditation Council for Graduate Medical Education. This council is responsible for the accreditation of more than 8,700 U.S. medical residency programs, representing 130 specialties and subspecialties, all to improve the quality of education for resident physicians. Dr. Zetterman's been the recipient of numerous awards, including the Burke Fizzy Clinical Achievement Award, which is the highest award from the American College of Gastroenterology. He's also received the Alfred Stengel Memorial Award for Outstanding Service from the American College of Physicians. This is the nation's largest specialty organization and the second largest physician group in the United States. And he was recognized for his exceptional contributions to the mission of the American College. He has served recently as the American College of Gastroenterology president and has contributed greatly to the success as we've moved forward with this Allegiant Creighton Health. So delighted to have you with us today, Dr. Zetterman.
Well, thank you very much for the chance to be here this morning. This is a wonderful opportunity, and it's an opportunity to talk about something that anybody who works in healthcare today knows it is a crucial time for us to look at how we provide integrated care. How we work in teams will change healthcare dramatically over the next lifetime, literally for all of us, and so that all of us have an obligation to figure out how we can make that work well. I'm going to try and touch on a few things about how healthcare integration is changing things, so I'll give you a little background on what I see as some issues. I'm going to talk a little bit about the regulatory forces that are here, and then I'm going to talk a little bit about interprofessional education, and that will be my three major topics. Now, this slide is something that you've all seen before at some time, but if you look at the top of the slide, this is gross domestic product down at the bottom and then healthcare costs going up there. And as you can see, most of the countries of the world, the industrialized countries of the world, have a pretty proportional relationship going up this thing of their gross domestic product and their costs, except for the United States, which sits way up there. In general, we spend twice as much per person in the United States on health care as virtually any other country outside of Switzerland, which tends to be a little higher, but otherwise than in the rest of the industrialized countries. And of course, you all know that if you look at who spends the money, it basically increases as we get older, and some of us are falling into those upper groups, so I pay a little more attention to this perhaps. But in fact, no surprise, end-of-life care for the elderly is one of our very expensive items. And if you back all of that down, it raises questions about how can we work in teams to do a better job of health rather than health care and trying to deal with it after things have changed. Now, we did a survey in the Nebraska Medical Association. This is actually done in 2008. It's before the economy collapses in the country. It's at a time the uninsured percentage in Nebraska was about 11%. So better than the national average, which is more than 16%. And if you look at it, it's the second one from the bottom, as I remember. Yeah, it is. 8 out of 10 Nebraskans were afraid they were going to lose their health care coverage. Yet, if you can see, 90% of them had to be insured. But that was their biggest fear. If you're out there self-employed on the farm and you have a bad drought, can you afford $12,000 to $15,000 for your family care this year? That's the issue that often pops up in those families. And I grew up in one of those families in south central Nebraska, so I have a very direct understanding of how that family has to deal with the vagaries of farm life and farm incomes. So as you look across this, Nebraskans were terribly afraid of the cost. They were afraid of losing it, all the things that were there. And 3 of 10 Nebraskans in 2008, remember this is before the economy collapses, said they had trouble paying for their health care during the prior year of time, whether that was for an outpatient service or an inpatient service or some sort of other visit, they had some sort of difficulty. And 3 of 10 Nebraskans postponed or skipped medical service in the past year. And this is where our health care issues really come home to roost, because we know people die because they don't have insurance, because they skip mammograms or pap smears or rectal exams or any one of a number of things that seem at the time to be unimportant in the life of that particular person. So why should we care about these things? Well, the United States is the only industrialized country that doesn't have universal health care coverage, and there's at least 48 million uninsured at any one time in the United States. And even though we have lots of programs for children, it still includes about 9 million children. There are at least 45,000 deaths every year due to lack of insurance. Again, people that avoid care do something and they fail, or they get chest pain and they fail to be evaluated, they get a heart attack and die. We published a paper in the American College of Physicians a long time ago. I would tell you that it could be 15 years ago about the literature on deaths from lack of insurance. And even though we spend twice as much as everybody else, in life expectancy, we're 47th in the world in order. In maternal mortality, can you imagine that we're 18th in this country in maternal mortality? Or infant mortality, we're 30th? There's a great YouTube video that I've used for the medical students that you can look it up on YouTube. It says, we're number 37. And it's a guy that wrote a song about the fact that we're the overall healthcare, we're 37th in the world. And so he documents the other 36 countries. And there's countries in there that you would just shake your head and say, how can they be better overall than we are? So healthcare spending is going to be a problem. It's going to continue to rise. We're already spending twice as much as everybody else. We're spending between $2.5 and $3 trillion now. It's expected to hit $4.3 trillion, some by 2017. We're spending 16% of the gross domestic product on healthcare. And there's actually somebody who's taken it out to the extreme, and by the turn of the next century, we'll spend more than 80% of the income of the United States on healthcare if we continue to climb at the same rate. 2007, it says 116 million adults that were uninsured or underinsured, because we have some people that do have some insurance, but it doesn't quite cover everything that they need, or that they reported a problem. Remember, 3 of 10 Nebraskans said that they couldn't pay for their care, or that they didn't have needed access because they didn't have some issue in being able to avoid the cost. And of course, the real problem is if we're spending $12,000 to $13,000 or $14,000 on family care today for an insurance policy, by 2020, it's suspected to nearly double along those costs. And the other thing about why we should care is, in Nebraska, if you have a family policy for your family of 4, the typical family, $1,000 of your policy costs are being shifted by physicians, by nurse practitioners, by PAs, by hospitals, by outpatient surgical centers to cover the costs of the people for those organizations that are either uninsured or underinsured. So if we had some sort of program in which everybody was covered, my policy should really drop by $1,000 at least in my overall coverage cost. And that's about $1 billion estimated to cost shift in Nebraska to cover the uninsured and the underinsured, as it says here. And it adds 16.5% to our insurance premiums overall. So what if we improved wellness? Well, this is an interesting statistic, and there's a number of things out there for you to think about. But if we had more activity. We got up and walked every morning, for example, before we went to work. If we ate better, we didn't smoke, we controlled our diabetes, we did all those sort of things, we'd have 80% of the heart disease prevented, 80% of the type 2 diabetes prevented. Remember, of all the states, every state in the nation has more than 25% of its members now classified as obese, except Colorado. It's the only one that is not. And we cut about 40% of the causes of cancer because fat has such a dominant role in driving carcinomas such as breast carcinoma, colon carcinoma, and others. This is an old Pogo cartoon about the environment in which at the very bottom Pogo says, yep, son, we've met the enemy and he is us. And I would submit to you that that's the problem where we are today in healthcare. So whether you talk about the environment or you talk about healthcare, the problems that we have, we've really done on our own. So will we be successful in solving our healthcare issues? Well, you know, the answer is we're going to need help. More than half of the healthcare costs are paid for by either federal or state governments. And unfortunately, I think this next slide probably sums up what the federal government is doing today better than almost anything else. You've got the federal healthcare reform on the left with Uncle Sam, and you've got the 4-year-old Congress over there running around chasing butterflies. You know, to me, that speaks an enormous amount. And I should tell you, if you ever ask me a question later, you'll find out that I am very pro-ACA. How can you have a country like this that doesn't provide health insurance for everyone? And I submit that we can't solve the cost problems until we have everybody in the system so we can look at the real costs that are there and have them reliably counted and paid for. So what are some of the changing healthcare practices that are going on now that will affect how we all deliver care and how we're all paid? Well, for example, fee-for-service, that's basically how we've paid physicians and nurse practitioners for a long time. That's gradually going to disappear, at least decline. You know, some will argue that it will always be there. But the real reason is that it's argued that it's unsustainable economically. We can't continue to pay for incident of care. And the problem is when you pay for incident of care, you may not pay any attention to the rest of the problems that the patient has. They come in and they get their flu shot and they walk out, or they come in and with their broken arm and we take care of it and they go home, but we don't look at their rectal exam or their mammograms or whatever else we need to do. It's going to be changed in this country. We're going to have organizations that will improve health and therefore limit hospitalization, and we'll talk about those in a little bit. There's a talk about going to bundled payments. So if I'm working for Allegiant Creighton Health, and I'm in Allegiant Creighton Clinic, and I discover a patient with colon cancer, then Allegiant Creighton Health will be paid one lump sum to pay for my discovery as a primary care physician, to pay for the colonoscopy that's done, to pay for the other things that the patient needs before their operation, to pay for the anesthesia, to pay for the surgeon, to pay for the hospital, and on and on and on. One bundle will come into the organization and then they'll partition it out. And they'll make a decision that that case of colon cancer costs X amount of dollars, and that's how they'll reimburse. Again, there's no fee for service in that particular model. It'll be replaced by integrated delivery systems. And that's basically what large systems like Allegiant Creighton Health will be as we go forward. And they'll provide comprehensive outpatient and inpatient care so that the patient will traverse through the system and have good care all the way along the way. And it'll be replaced also by models that reimburse specifically for quality of care. Remember today in fee-for-service, the outcome is not how the physician or the nurse practitioner or any of the other providers are paid. It's simply the incident of care along the way. Well, these are the definitions from Wikipedia of accountable care organizations and medical homes. You know these definitions. The accountable care organization will be that kind of an organization characterized by payment and care delivery that ties reimbursement to quality. So your reimbursement will eventually be, if you have great outcomes, potentially you're going to get paid more. If you have bad outcomes, you may not get paid at all. And of course, the medical home is what a lot of people would have said for those of us growing up. Our old family physician was like, in which he or she looked after us and made sure that we had all our shots, and that if we had a family history of something that we got looked at and cared for. but it's a team-based sort of home care delivery system that takes the advantages of the nurses and the physicians and the other providers in that system to make it work. We've got to work in teams, and I think that's the real issue that's here today. And this is not an easy issue. This is I think, a very difficult issue for us to talk about how we can educate in teams across the nursing, medical, and pharmacy schools, let alone dentistry, physical therapy, occupational therapy, clinical psychology, all the things that we might want to roll together. So what are some of the characteristics of a team that I look for? And these are also been written about by a variety of subjects, and I took some of these out of some articles that I was reading. You would all agree there's a clear aim. What's the team's aim? We're going to provide the best care we can possibly care to every patient. We're going to have the best environment for care and the best place to work, all those sort of things. We all understand the goals and share them. We'll have clear processes. We'll build processes that every type 2 diabetic is taken care of in exactly the same way with the modifications that they need because of other complications that pop along the way. I talk to the students about communication, and I remind them that the most important part of communication is to listen. And again, I would think that's a team characteristic. You got to have a structure that's flexible because things will change. So you got to have somebody that's in there and leaders. You got to have skilled staff. You got to bring everybody up to the level that they need to be, have the quality and safety measures that they need, and have plenty of money. And that'll be some of the problems for the accountable care organization in the medical home, because we'll add processes into them that aren't just about incident of care. So we'll have to figure out how we're going to pay for that particular group of people. Team members need to learn. They need to learn about each other. They got to figure out what are the skills. What does each person bring to the team? How do they communicate? We all communicate differently with each other. And actually, some of those things are specific to the type of person we grew up as in our educational way. Team members need to communicate, and I've already told you that's about listening. And they need to maximize their activity. Have everybody work to the top of their level. A number of years ago, I spent a sabbatical with a group, a healthcare reform group. And we actually talked about the fact that maybe we needed to do away with the licensure laws that we have today and let the organizations certify the people that work and let them come up with their unique skills rather than simply relying on a degree that gives them some skill that somebody else doesn't have. So I'm not sure where we'll go, but I don't see states doing away with their licensure requirements anytime soon. What are the sort of issues that the teams need? They need a common health record. You've heard about the personal records that are there. Those are wonderful along the way. You need a common place to work together. That's how you listen to people. That's how you find out how people communicate. In the clinic, sometimes that's a morning huddle. You get your person at the front desk. I learned a long time ago that the most important person in the clinic was certainly not me. It might not even have been my nurse, but it was usually the person at the front desk, because he or she usually knew a lot about the patients that were coming in, saw how they acted and behaved. And I always said, you know, if I ever moved to another clinic that I was going to run, and I had a really good front desk person, I'd make sure I took that person with me. A willingness to learn about each person's role inside the team. A willingness to hear new ideas. A willingness to learn new skills in communication, in physical activity, in a variety of ways along the way. More importantly, perhaps than anything else, a willingness to be taught by others. You know, I'm old enough that I grew up in the era as a house officer of the night supervisor, a nurse. And it was almost always a woman as I was training. I guarantee you she knew more medicine by far than I ever did. And I survived many a night because I was willing to let her teach me about some of the changes of healthcare and of healthcare learning that I needed to know. And perhaps that's also where flexibility comes in. So how do we train in teams if we're going to do this? And as I've said, this is going to be very difficult. Well, here's a definition, pardon the misspelling. It's to, not toe. Here's a definition of interprofessional education that's commonly used. Occasions when two or more professions learn from and about each other to improve collaboration and the quality of care. And this is a spectrum of learning from others, a non-threatening learning environment. You've got to learn together. You've got to be willing to share. You've got to be willing to understand each other. You have to be reflective, not just about lots of things, but about yourself and what your skill level is and what you need to learn. You got to have relevant learning experiences, and I think that's where we start to have difficulty when we talk about training nurses and physicians and pharmacists, for example, all together. And use teaching and learning strategies, and I think small groups are the one thing we can do, and we've started to do that more and more, but we've got a long ways to go in finally getting there. There are some barriers, no question about it, to interprofessional education. We don't know a lot about each other's professions. Oh yeah, we know. We can pick out a nurse or a physician or a pharmacist, but that's not what it's about. It's about learning about our professions and how they steep us in our traditions and bring us forward. We've got to be willing to solicit contributions for others, so I need to be willing to listen to the pharmacist when he or she says to me, here's what I know about this drug and where it may be a problem for your patient. We've got limited capabilities in communication, back to the listening issue. Maybe more important to listen than it is to talk. We have limited opportunities for educational processes to occur together. We all have intense educational processes in our schools. And to think about how we can put 3 groups together, we have enough trouble scheduling our own school, let alone trying to schedule 3 schools or 4 schools together or 5 schools or whatever it is. But attitudes is where it is. Attitudes is where we have to break down the barriers along the way. And of course, we've got to have some opportunity for structured and progressive learning opportunities. We don't see things as they are, we see things as we are. And I think there's the dilemma for interprofessional education. Change is hard, so how do we make the changes in education that can lead to interprofessional education? Well, there are some opportunities in social learning. We have a collection of students at Creighton that provide more service than any other school I've ever been associated with. They all love to do all sorts of outreach and do things. Maybe we need to put them together because they'll learn about each other and how each of their professions approaches problems, sometimes just simply in social learning environments, in working in a free clinic, and in just doing fundraising or any one of a number of things they might do together. There are schools now building electronic hospitals. You sign on as for example, you're a medical student, you sign on as a physician, and you have a virtual hospital on your computer that will let you go through admissions and patient care and a variety of things, will let you interact with other people in there who are nurses or pharmacists or physical therapists or psychologists or whatever else are there. So social learning can be one step we might consider. But experiential learning is what we all want and desire. Should we be in the lecture hall together? Sure. There's a bunch of things that we can do together. Should we have courses on interprofessional learning theory for all of our instructors? Yeah, it sounds good to me. I certainly have a great need to learn more. Can we work in simulation centers? Can we have interacting learning and problem solving, again, inside of assessment or simulation centers? You bet. If you put a team of students together trying to solve patient care problems in an environment where you've got a mannequin that can do all sorts of things, that looks and acts and feels like a real hospital, you can build ORs that do the same thing and work with OR teams, or ERs that work on ER patients coming in with trauma. They're simulated patients or whatever. You bet we can do that. We need to do more of it. It's not cheap, it's not easy, but it's doable. Can we have interacting learning sessions during inpatient care? Of course. We put our students and our residents and everybody else together. Same's true in the clinics, learning that there are vital people in the clinic besides each one of us. But it really comes down, I think, as much as anything, to a fairly radical change in how we currently train our healthcare workers in going forward. So these are the key messages. I took this from an article in 2001 from one of the Canadian schools, and I think it really hits the key messages that I'd want to take home. Collaborative working between professions is a key to quality care. Interprofessional education strategies have to be looked at, done, and rewarded. Barriers to interprofessional education won't disappear simply because we ignore them. And of course, it must enable students to recognize, value, and engage with the difference arising from the range of health professional knowledge and health professional practice. Thank you so much for the chance to come and talk with you this morning. Sure. Yeah, there's some questions. Anybody have a question? People are stretching, but they're not asking questions. Yes, ma'am. Yeah, so the question is, who's the leader of the team? Can it be anybody? And the answer is, of course it can. You know, the answer is, it really depends on the circumstance and what's going on more than anything else. But, you know, if you look at, there's a great article that just came out this week about the airline industry that talked about how much we've improved the safety of airlines. You all know when you were a child that you heard about crashes periodically almost every year. Thank God, because we all fly a lot. We almost never hear about a plane crash. It's because they changed it. The captain of that plane is no longer the absolute, unequivocal leader of that plane. Everybody has the right to raise a question. And when I was a chief medical officer, one of the things I always asked, putting in central lines, you know, we built an algorithm for what you have to do to prepare the patient to put in a central line. And the question I always asked when I went around and said, talked to people about it, to a nurse or a tech, it could have been actually somebody just on the ward who was walking by, or a medical student or anybody, can you stop the process if it's not going the way we say it should be done? And if everybody can answer yes, that you know, so to speak, almost the janitor walking by who understands the process could say, wait a minute, you don't have a gown on that patient, you know, you haven't draped them properly. That's when you know you've come to the place where you have a team where everybody works together and they're all willing to stop the train. That's what Toyota did, although Toyota got a little blemish here recently with some of their automobiles. You'll remember that's how they put their quality into place. Anybody on the assembly line could stop the assembly of a car if they thought there was a quality problem. That's where we need to be with teams. That's where we need to be with healthcare. And teams should depend on who has the time and energy to run those teams more than whatever their degree is. You bet. We do have a plan moving forward for Creighton. We have a simulation center plan that's in process. We're about roughly 3/4 of the way towards the funding that we need to put it onto place. Now, saying that, actually we have very good simulation centers inside the School of Nursing, inside the School of Medicine, inside the School of Dentistry. Pharmacy has some simulation. What we don't have is one central place where they're all together. And that's the goal of our simulation center. Some call them assessment centers also, because that's where you bring in your simulated patients, you know, the person that can fake something. We have a simulated patient who can fake a heart attack so well in the School of Medicine that one of the students rushed out and said, you've got to call 911. This guy's having a heart attack. Well, fortunately, she made the right diagnosis, but of course, this guy had a little spritzer, so, you know, he could spritz his face and look like he was sweating, you know, and he's in there. And so, you know, we need to be together. That's when we're going to be home free with our simulation center. And so we actually have a very active group right now looking at it, and it is multidisciplinary. And it'll be largely medicine, nursing, and pharmacy. Dentistry will come in when they have special needs, but they actually have their own simulation center because obviously they're doing dental simulation. Somebody had a question over here. Yes, ma'am. And as I understand, you also celebrate it with something called Schwartz rounds, am I right? That's the proper name, so that you get together to do a grand rounds in which all those people are there and they all tell about their portion of the care of that patient. Now, Now, the question's about how do the payers fit into this and making it work. You know, I think the real issue is if I was going to build a medical home as a family physician, I'm going to take care of the patients whether they come into my office or not. I mean, that's really what a medical home is about, so that if I recognize it's time for Mrs. Jones to have mammograms, you know, we're going to call her up, we're going to ensure they get done and all that. That takes personnel time. I'm only paid, however, if Mrs. Jones comes to see me. Same would be true for a nurse practitioner. So we need some sort of basal funding to operate those sort of programs. We might still get a fee for an incident of care when Mrs. Jones has pneumonia and needs to be put on antibiotics or whatever, but we'd get some sort of basal funding. I think we're going to have to look at it, and that's where the Accountable Care Organization now is kind of superseding that. They probably will have a mechanism in which they get some sort of funding along the way. They'll share in the profits of the patient who avoids hospitalization, and then that the insurance company now doesn't have to pay out, and that's how they'll maintain their funding. So it'll definitely will require some changes along the way from what we largely still do in this country.
The ACOs are mandated to have the care management as part of the ACO.
Thank you so much for your time and attention.